Greetings, everyone. Um, Today, I'm very privileged and very pleased to have this opportunity to share some of the research I have been conducting with Meg. So, my name is ReginaAbotsi. I'm a 2019 Meg South African Program grantee, and I just recently completed my PhD at the University of Cape Town, South Africa. Today, I'm going to share some of the findings of my research work with you. And the title of my talk is Old Solutions for New Problems, Chronic Lung Disease in Older Children with HIV. I'm going to begin with a brief personal background, and then I'll talk about my research and our main findings. So I was born and raised in a small town in the Volta region of Ghana, West Africa, called Anglonga, as we can see on the map on the slide. And as I was growing up, I was very fascinated and intrigued by drugs, how drugs can alleviate things like pain, clear infections. I was so intrigued by them. So that forced me or led me to pursue an undergraduate degree in pharmacy and became a registered pharmacist in Ghana. During my pharmacy school days, when I learned about antibiotics, that was the new focus of my fascination, and I wanted to understand it more. And I was particularly intrigued by what seemed to be a tug of war between humans and bacteria. We come up with new antibiotics, and we see that later that the bacteria seems to be one step ahead of us in developing mechanisms to outsmart our antibiotics. So that really interested me. And the part which alarmed me was the fact that if we don't deal with our antibiotic resistant issue, we might be taken right back to the pre-antibiotic era where a simple paper cut can prove fatal to a person. So because of that interest in antibiotics and antibiotic resistance, I pursue both my master's and my PhD programs focused on antibiotic resistance. So my master's degree I completed in University of KwaZulu-Natal, South Africa. And after that, I took a position in University of Health and Allied Sciences in Ghana as an assistant lecturer of pharmaceutical microbiology. I took up this PhD position at the University of Cape Town, where I looked at antibiotic resistance in the context of children living with HIV in Sub-Saharan Africa. So the findings from my research work is what I'll be sharing with you today. So according to the WHO estimates, about 4 million children are living with HIV globally. And out of those 4 million, more than 90% of them live in Sub-Saharan Africa, as we can see the red coloration of Africa here. Now, the main route of infection for these children is through mother-to-child transmission. But then the rate of this occurrence has declined dramatically as a result of the scale-up of public health interventions that targeted this phenomenon in order to prevent it. Concurrently, increasing number of African children who were already infected with HIV through their mothers during the peak years of 1995 and 2002 are now reaching adolescence and adulthood, and they haven't been diagnosed and treated by their national HIV programs. As this group is reaching adulthood, they are presenting at healthcare centers with chronic diseases that differ from adults living with behaviorally acquired HIV. And these chronic conditions include growth failure, neurological problems, but most notably, chronic lung diseases. Now, these HIV-associated chronic lung diseases are responsible for more than 50% of all HIV-related illness and death. And these chronic lung diseases include tuberculosis and bronchiectasis. Recently, my research team detected a novel and previously undetected chronic lung disease in older HIV-infected children in Sub-Saharan Africa, specifically in the countries of Zimbabwe and Malawi. And this condition is called obliterative bronchiolitis. It is one that we have estimated the prevalence to be more than 30%, meaning that for every 3 older HIV-infected child, a child living with HIV, at least one of them has this lung pathology or disease. Now, obliterative bronchiolitis affects the small airwaves within the lung, as we can see in the image here. This is a normal bronchiole. It has a thin layer of smooth muscle and a wide lumen available for gaseous exchange. But the clinical picture for that of obliterative bronchiolitis is somewhat different. We see that there's a remodeling of the bronchiole, where specifically we see that the smooth muscle layer, which was thin here for a normal bronchiole, is thickened, and it narrows the lumen available for gaseous exchange. As such, sufferers from this condition, they present to the healthcare centers with symptoms like breathlessness, fatigue, and reduced exercise tolerance, among others. Now, the cause or the pathogenesis of this particular condition is something we don't fully understand, but we speculated by it might be the result of the repeated respiratory infections that these children who have HIV and are growing in sub-Saharan Africa, where infection burden is high, they experience, coupled with the chronic inflammation that exists within HIV itself. As such, a treatment or a drug that may be effective in managing this condition must be able to tackle the infectious component of it and also the inflammatory component of it. And one such drug is azithromycin. So azithromycin is an antibiotic. It has both antibacterial effect and a microbial effect, and it also has potent anti-inflammatory properties. And we hypothesized that it might be beneficial to this patient population. So to test this, we set up a clinical trial in the 2 African countries where we detected this. And the clinical trial is called the BRIEF clinical trial. So we enrolled or recruited children who acquired HIV through their mothers at the Queen Elizabeth Hospital in Blantyre, Malawi, and Harare Children's Hospital in Zimbabwe. So we recruited children aged 6 to 19 years who we established acquired HIV through their mothers and who have been on antiretroviral, which is HIV treatment, for at least 6 months. And once we recruited them and they met our eligibility criteria, we randomly divided these children into 2 groups. The first group, or one group, received azithromycin treatment. The other group received a placebo treatment. And the placebo is just an identical looking tablet to the azithromycin, but without the active ingredients. And both groups received the treatment once weekly for 48 weeks. At the end of the study, we observed that the participants who were in the azithromycin group, they were less likely to experience worsening of their symptoms, and they were also less likely to experience, to be hospitalized for any reason whatsoever. So the results from the clinical trial we published in a scientific journal called JAMA, as we can see here, and this is just 2 of our participants involved in our study. So in essence, we found that, or we proved that azithromycin is beneficial to these patients. But then, because it's an antibiotic, we have concerns about antibiotic resistance, because it's been established in literature that where there is antibiotic exposure, it's followed by a consequent development of antibiotic resistance. The case of antibiotic resistance just is a phenomenon where a bacteria that previously was susceptible or can be eliminated by a particular antibiotic develop ways to outsmart the antibiotic. So any infection resulting from that bacteria will not be cured by that antibiotic. So we were not sure the extent to which this antibiotic resistance problem occurs or within our patient population in response to the treatment that we gave them. And we also didn't know how long or for how long this antibiotic resistant problem may persist. So to be able to answer these questions was the focus of my PhD work, nested under this clinical trial. So we collected samples from the upper and lower respiratory tract. Specifically, we collected nasopharyngeal swabs, which most of us are now very familiar with because that is what we preferentially use for COVID testing. So the nasopharyngeal swab was to characterize what is going on in the upper respiratory tract. And then we also collected sputum samples to be able to determine antibiotic resistant levels within the lungs itself. So to establish the baseline antibiotic resistant levels, we collected the respiratory samples during enrollment before we started administering the treatment. Then we also collected samples at the end of treatment, which is after 48 weeks, in order to establish or to find out how the antibiotic resistant levels have changed. Then, because we're also interested in understanding how long antibiotic resistance, which may have been increased as a result of the treatment, how long it persists, we also collected the same sample types after 6 months of end of treatment, which is the 72-week time point. And all the samples that we collected, I ran microbiological analysis on them in the lab. So what did we find? So generally, we found that azithromycin taken for about a year, which is the 48 weeks, reduce the carriage of common bacteria that cause respiratory infection. And we can see that. I don't want to bore you with too much technical information from my results. I just want to show you a cross-sectional data. So here, cross-section of my data. So here we see that the indigo bars refer to the azithromycin group and the green refers to placebo. So we see that for a cross-section of the bacteria that we tested for, we see that at the 48-week time point, which is the end of treatment, we see a reduction in the carriage of the first bacteria, the second one, and the third one. Then we also noticed that although there was a reduction in the carriage of this bacteria, there was an increase in an antibiotic resistance in this bacteria. But then the fortunate thing is that the resistance levels returned to baseline 6 months after the end of treatment, except in the case of the important bacteria, Staphylococcus aureus, where the resistance remained high, as we can see here. So based on my research, we concluded that azithromycin, currently the only drug that has been tested and found to be beneficial to these patients, can be used to prevent the worsening of this condition without major concerns of antibiotic resistance. And this would reduce the absenteeism and the disruption in the education of this older children living with this HIV-associated obliterative bronchiolitis. And overall, it will also improve their quality of life. I will not have been able to complete this work without the kind grant support from MEG. Due to the COVID pandemic restriction and disruption, my PhD extended beyond the period allocated for my original funding. And the MEG funds allowed me to be able to support myself and my dependents in the months leading to the completion of my PhD. And I would like to use the opportunity to thank all the donors for their generous support that they continue to give to MEG, and also to just highlight that, yes, the grant go a long way to support quite a number of us women involved in research that seeks to improve the lives of women and children. I also like to thank the MEG president, Magdalene, and also the board members and all the hardworking individuals that have been working behind the scenes to make this grant available to us. And we are very grateful. As a result of the work that I've conducted, I received a number of awards, including the prestigious L'Oreal UNESCO for Women in Science Sub-Saharan African Young Talent Award for my work. And the pictures you see on the screen are from the event in Senegal in 2019. I'd like to use this opportunity also to thank my supervisors and also collaborators and the entire brief study team. But most especially, I also like to thank the brief study participants and their families, without whom the study wouldn't have taken place. I also like to thank our funders and all the institutions that have supported this study. Finally, I would like to thank all of you for taking time off your busy schedules to come and listen to this talk. I will be happy now to answer any questions that you may have. Thank you.